Welcome back to our recurring AHBI webinar series. This is something that we do every 2 to 3 months. And the best thing about our webinar is it's free of any industry conflict. And that's what we try to do. And thanks to our great faculty who always volunteer their precious time for these webinars. And we are learning a lot. And most of these webinars are recorded, and we share that on our YouTube channel as well as on our WooMedi channel. And all these talks will be available for free as well after the meeting. So today we have a very interesting topic, and this topic was suggested by Dr. Gulati, which is cardiologist, nephrologist, and endocrinologist walk into a bar, understanding SGLT-2 inhibitors in the hashtag cardio-nephro-endo space. And I know we have a lot of disagreement between nephrologists and cardiologists over Lasix, but that is something that we we both agree with. And then on top of that, we have an endocrinologist today who can vouch for it and who can be a truce maker. So Today's panel include, Dr. Hiremath from University of Ottawa, Dr. Ibrahim, Dr. Javed Butler, who's the PI for Emperor, Preserved, Emperor Reduced, and Dr. Harold Bays, who is an endocrinologist, and then we also have our co-moderators, Dr. Martha Gulati and Viet, and this would not be possible without them. For this meeting, CMEs and MSCs will be provided by Steward Health, and this is the website and the barcode where you can claim those after the meeting. So without further ado, I would like to invite Dr. Hiremath to talk about cardiorenal syndrome, or the nephrologist perspective.
And go ahead and stop screen share there, Dr. Khan, and that will allow Dr. Hiremath to be able to share his.
I'll make him co-host. Is that how he will share the
that will work as well. Yep.
Okay, all right.
Okay. Thank you. I hope everyone can see my slides.
Yes.
Thanks for the invitation again. And I'm, as Martha has said, I'm the lone Canadian and I'm the lone nephrologist in this crowd. I hope I can entertain you. There are, far more greater experts in the panel than me on this topic, but I'm just going to share and set up the stage from a nephrology perspective. I work in the University of Ottawa and the Ottawa Hospital Research Institute, and it's a beautiful city, as you can see there. So in terms of disclosures, I don't have any financial conflicts. I have peer-reviewed funding from CIHR, which is our equivalent of the NIH, and I get research support. But I have a huge non-financial conflict, is that I'm an avid flossinator. I wake up in the morning and I ask myself, what am I going to do today? So in terms of the learning objectives for this session, of course, it's to summarize the latest updates in cardiovascular treatment and prevention and identify novel ways to manage disease progression. But the real objective, there's always a hidden curriculum. And today's hidden curriculum is that you should stop saying the word SGLT-2 inhibitor and start and embrace the word flozin. They are flozins just like they're statins. So start saying flozins and become a flozinator. And ask yourself every day in the morning, look in the mirror and say, am I a flozinator? Who am I going to flozinate today? So yes, if you look up anything on CKD or chronic kidney disease, you will see that people say there is a kidney disease epidemic. For example, the CDC says more than 1 in 7 have a chronic kidney disease, and in diabetes, it's 1 in 3. Now, I will let you in a little secret that nephrologists don't tell you. It is that most patients with CKD don't develop kidney failure. They actually die, sadly, before they develop kidney failure. So it's cardiovascular disease really that's important. Kidney failure, yes, does happen, but it's in a smaller minority. And if you look at, say, dialysis patients, this is an old slide, which is really a seminal paper from over 20 years ago. it tells you that a 25-year-old dialysis patient's risk of dying is the same risk as the of an 85-year-old with no kidney disease. And then this was another paper from Kaiser Permanente, which showed that as the GFR decreases, the risk of cardiovascular disease actually goes up. So the reason kidney disease matters is not because it causes kidney failure, but decreasing GFR matters because it is a risk factor for cardiovascular disease. In fact, it's one of the most robust factors, risk factors for developing cardiovascular disease. So CKD patients mostly die of heart disease. You know, as a nephrologist, as a card-carrying nephrologist, I have to admit that it's the heart that matters. The heart is not just a pre-renal pump. The kidney disease actually increases the risk factor for heart disease. But you know, preventing kidney failure is important, right? I just don't want to do dialysis. But from ACCORD and the diabetes literature, we know intensive glucose lowering doesn't lower kidney failure. We know that intensive BP lowering also does not. For example, this is from the BP lowering trialist collaboration. And you can see that BP lowering decreases, give me 1 second, decreases the risk of everything. It decreases the risk of dying, it decreases the risk of cardiovascular failure, but it does not decrease renal failure. So, you know, we have been struggling. There are so many things we have tried and nothing has worked until recently for decreasing kidney failure. You know, so while the cardiologists are, you know, having statins and antiplatelets and you know, interventions and the ARNI, we have been wandering around in the fog in the wilderness with nothing to offer to our patients until, you know, there was something that came 5 years ago. And the story begins with Adam and Eve. No, I'm just kidding. It's the apple, right, which is the key. So the skin of the apple is where fluorescence was first discovered from. But if you look at when EMPIRIC came out, it was cardiovascular outcomes. So kidney outcomes were not the primary outcomes, they were not the secondary outcomes, they were not the tertiary outcomes, but they saw that, oh, wow, you know, there was a huge reduction in kidney outcomes. And if they had paid attention, I'm just bragging here, a year earlier, I had written a blog saying that, you know, SGLT-2 inhibitors may have a role in not just in the treatment of diabetes, but in the prevention of diabetic nephropathy. It's because of the mechanism that they act. But without going into the mechanism, I just want to show briefly this systematic review by a couple of buddies, Christoph Argyropoulos and Michael Johansson. And the reason they are smiling is because of the effect of fluorescence that they can demonstrate. So fluorescence cause a 15% reduction in cardiovascular death. This is phenomenal, right? And they cause a 15% reduction in all-cause death. You know, show me something that does that. You know, after statins, these are even bigger than the statins when it comes to risk reduction. And when it comes to adverse effects, you know, maybe there's a little bit of increase in UTIs. Yes, there is more genital infections. There is more hypovolemia. So you would expect there would be more AKI, but no, there is less AKI. And if you see this, again, this doesn't have the latest data from the trials that have come out, but there is a reduction in kidney outcomes. There's a reduction in AKI. There's actually a reduction in hyperkalemia, unlike, for example, RAS inhibitors. So they reduce the risk of kidney failure by about 30%, reduce the risk of AKI by about 30%, and they reduce the risk of hyperkalemia by about 40%. These are huge numbers to get excited about. And it's not just trials, you know, this is the real world data from administrative databases. It shows a reduction in AKI, even in the real world. To keep in mind, of course, what is important is that this is from the Credence database, and it shows that the benefit of fluorescence is consistent across all levels of albuminuria. It was consistent across all levels of GFR and CKD stages. The other interesting aspect is that, you know, in the earlier trials, not everyone was on an ACE inhibitor or an ARB because they were being used as diabetic agents. So yes, you know, the confidence intervals may seem to cross 1, but even in patients without RAS blockade, there was an impressive benefit with fluorescence in the risk reduction. This is from Brendan Nguyen from George Institute, who has done many of the really good secondary analysis from the fluorescence trials. So yes, you may think about, you know, heart or kidney and how does it act? And the word pleiotropic is often thrown about. There's a really nice paper from Richard Gilbert, who's in UHN in Toronto, who suggests that maybe SGLT-2 inhibitors, you know, they are like the beta blockers for the kidney. I would say, you know, who cares? Who cares how they act? They just act. They are fantastic when it comes to reducing cardiovascular events. And I'm kidding to some extent. We really do want to know how they act because, you know, maybe they'll tell us about developing even better agents, even better fluorescence, or they'll understand, they'll increase our understanding of the progression of kidney failure, heart failure, and so on. But really, we should not think about, is it the heart that is, they are having an effect, or the kidney, or the weight loss, or the diabetes. The pathway doesn't matter. You see empiric evidence of heart outcome benefit, and that is all that matters, I would say. So Flozins work, again, they work for diabetes, they work for proteinuric chronic kidney disease. We don't have data yet in non-proteinuric, non-diabetic chronic kidney disease. They work in HFrEF, as I'm sure you will hear soon, and HFpEF. So there's only a small minority of the humanity who should not get a Flozin yet, and it's just yet, right? I'm sure it should be added to the drinking water soon as more and more data comes out. And the patients that we typically see have one of these conditions, right? I don't see anyone who would not fit a criteria for getting a Flozin almost, unless they're probably on dialysis anyway. So with that, I don't want to take up too much of a time. I just want to emphasize that you should all become a Flozinator. And we can discuss, these are the papers that I cited, which if you view the recording, you can view in leisure. But with that, I did not set myself up too much, I hope. But we'll go on to the next session now for Dr. Ibrahim to expand on this topic. Thank you.
Thank you, Dr. Hiremath. That was such an excellent talk. And just, I think we sort of forgot to introduce you and tell where you're from, just for everyone to know, not only is he Canadian, but he comes from University of Ottawa, where he's an associate professor and obviously the nephrologist part of this program, and has been a leader in really using social media actually for education, which is how I found him, was that he heads up the journal club online, JC, I believe, and we've copied off of him in the cardiology community and started doing similar things to what the nephrologists are doing. And they wanted something like a statin. I think they have it in the Flozinators. We see the cool jacket he has and all the cups and everything that go along with Flozination. So our next speaker, she can start putting up her slides, but Dr. Nasrein Ibrahim comes to us from Inova. And she used to be, probably many of you knew, she just recently started at Inova, but she was at Mass General Hospital. She's a heart failure specialist, and right now she's the director of heart failure research at Inova. And she is one of the two cardiologists. We had to outnumber everybody else, right? We couldn't let the endocrinologist and the nephrologist be alone on this stage without two cardiologists. So we're excited to hear from her on heart failure with reduced ejection fraction and the new therapies that are out.
Thanks so much, Dr. Gulati, for the invitation. It was awesome doing this last year when we were, I guess we still are in the midst of the pandemic, but it was when we first started using these Zoom platforms. So I'm really excited to be back. And as Dr. Gulati said, I will be talking about new therapies on the horizon for patients with heart failure with reduced ejection fraction. These are my relevant disclosures. So I'll start with just a review of the 4 pillars of guideline-directed medical therapy in patients with HFrEF. And as you know, these therapies reduce morbidity and mortality. We have the ARNI, the only one we have right now is sacubitril valsartan, evidence-based beta blockers, including metoprolol succinate, carvedilol, and bisoprolol, the mineralocorticoid receptor antagonist. We have spironolactone and eplerenone, and the SGLT-2 inhibitors, which we'll hear about more in the next talk, empagliflozin and dapagliflozin. And I'm glad you said that we don't understand the mechanism yet, because I was stumped with this question earlier when I was giving grand rounds. So we know this is the background therapy that all our patients need, but what is new is this need for speed. And I recommend you read this viewpoint. And I'm not just saying that just because Dr. Butler will be speaking next, but it's an excellent viewpoint in JAMA Cardiology, where Drs. Green, Butler, and Fonerode talk about this concept of rapid initiation and rapid titration of the 4 pillars of guideline-directed medical therapies. And lots of societies, including European societies and Canadian societies, are also talking about the importance of rapid initiation and titration. And in this algorithm, they talk about getting to either the target doses in the clinical trials or the maximum tolerated doses within 42 days. And again, every patient is different. There might be some patients that are able to be titrated quicker, other patients that might need a little more time. But the idea is making a plan and getting things, the 4 classes initiated and titrated rapidly. And after that 42 days, a determination of whether the patients need maybe drugs that are in the have class 2 indications, whether patients need devices like ICD or CRT, or whether patients are just not improving and still remain very symptomatic and warrant consideration of advanced therapies. So the benefits of rapid initiation and titration include rapid improvement in health status. This is usually within 1 to 2 weeks, rapid reduction in heart failure hospitalizations, rapid improvement in LVEF within 12 weeks, rapid reduction in mortality, and then this idea of overcoming inertia. And we see inertia can be multifactorial, including from the clinician standpoint, from the patient standpoint, and also from a system standpoint. Sometimes rapid titration initiation may need a lot of resources which are not available at certain institutions or clinics. So after those 4 pillars of GDMT, there's still more to go. So I'll start with vericiguat, and this is Victoria, which was published last year. And vericiguat is an oral soluble guanylate cyclase stimulator. And these were patients that had heart failure with reduced ejection fraction. In this trial, it was defined as an EF less than 45%. All were hospitalized in the 6 months prior to enrollment, and most were actually hospitalized 3 months prior to enrollment. The average age of patients here was about 67, and patients were well treated on background GDMT. The primary outcome here was a composite of death from cardiovascular causes or first hospitalization for heart failure. And what the investigators found is that in patients with worsening HFrEF, the patients that received vericiguat had a significant reduction in the primary composite outcome. This was primarily driven by a reduction in heart failure hospitalization. As you can see here, when they looked at death alone, there wasn't a reduction in cardiovascular death. So where does vericiguat fit in the picture? We have a full armamentarium of 4 classes of guideline-directed medical therapies. Well, the FDA approved vericiguat in January of this year for patients with HFrEF that have worsening heart failure. And they defined this as patients that required a hospitalization for heart failure or patients that needed outpatient IV diuretics. So something to keep in our back pockets for patients that are optimized on the 4 classes of GDMT, but are hospitalized or requiring IV diuretics. The next drug that's on the horizon, omecamtiv mecarbil. This is a novel selective cardiac myosin activator or a myotrope. And in COSMIC-HF, it was shown to improve cardiac structure and function. It reduced NT-proBNP, which is a biomarker, which is a good indicator for outcome in patients with heart failure, and it improved health-related quality of life. But the question became, what about cardiovascular outcomes? And this is where GALACTIC-HF came in. This was a study of omecamtiv mecarbil in patients with systolic heart failure, defined here as EF 35% or less. They were symptomatic. They had New York Heart Association class 2 to 4 symptoms. They had elevated BNP, and they were already on a background of good medical therapy with traditional GDMT. Patients were either hospitalized for heart failure, or if they were outpatients, they had an urgent ED visit or a heart failure hospitalization within a year prior to screening. What I thought was pretty striking in the exclusion criteria was that the systolic blood pressure was pretty low. So to get enrolled in the trial, you only had to have a systolic blood pressure of 85 or higher, which tells you that they enrolled sicker patients in this study. So patients were randomized to receive omecamtiv on top of standard GDMT versus placebo. And at week 2 and week 6, there was pharmacokinetic assessment for dose adjustment of omecamtiv. Some of the baseline characteristics that I thought were notable: most patients had a heart failure event within 3 months prior to enrollment. The mean LVEF was less than 30%. Most patients had class 2 and 3 New York Heart Association symptoms, and over 50% of patients had ischemic cardiomyopathy. 40% were diabetic. NT-proBNP at baseline was 2,000, which is quite high. And all were well treated on background therapy. Almost 90% were on a RAS inhibitor, over 90% were on a beta blocker, almost 80% were on a mineralocorticoid receptor antagonist, and a low percentage were on SGLT-2 inhibitors, which makes sense because these were the newest kids on the block in terms of our background GDMT. So the primary outcome here was time to first heart failure event or cardiovascular death. And as you can see, in patients with hospitalized or have evidence of worsening heart failure as an outpatient who received omecamtiv mecarbil, they had a significant reduction in the primary outcome. Here as well, the primary outcome was driven by a reduction in heart failure hospitalization. And if we looked at the subgroups, it appeared that sicker patients did better with omecamtiv. So, patients that had New York Heart Association class 3 or 4 seemed to do better with omecamtiv than those with class 2 symptoms. Patients with lower EF, so 28% or less, seemed to derive more benefit. And then patients with higher NT-proBNP, whether they were inpatient or outpatient, that had above median concentrations of NT-proBNP. This was a sub-study from Galactic HF, and the question was that the team wanted to answer was whether or not patients with lower EF derived more benefit. And they found that patients treated with omecamtiv mecarbil had greater relative treatment effect and larger absolute risk reduction for the primary composite endpoint with lower EF. So again, potential for this drug or this therapy in patients who have more severe heart failure. So omecamtiv mecarbil is not approved for use, but we're thinking about the future. So where would omecamtiv mecarbil fit in the puzzle? Well, omecamtiv did not reduce blood pressure, and also it had no adverse effect on kidney function or potassium. So it could potentially be used in patients that don't tolerate traditional guideline-directed medical therapies, because most of the therapies we have lower blood pressure. And the MRAs and ARNIs, for example, have an effect on kidney function. So either in patients that already have kidney function that's prohibitive of starting these therapies, or patients that just don't tolerate the traditional guideline-directed medical therapies. Additionally, we might consider use of omecamtiv mecarbil in the future in patients with more severe heart failure, those with EF less than 30%, sicker patients with New York Heart Association class 3 or 4 symptoms, and elevated NT-proBNP. So in conclusion, you should optimize the 4 pillars of GDMT first. Think about the need for speed with ARNI, beta blocker, MRA, and SGLT-2 inhibitor. The benefits happen quickly and early, including reduction of mortality, reduction in heart failure hospitalization, improvement in EF, and improvement in symptoms. After that, if your patients are still symptomatic and having evidence of worsening heart failure, either because they're admitted to the hospital for heart failure or they're requiring outpatient diuretics, consider adding vericiguat. And then keep your eye out in the future for omecamtiv mecarbil and its potential use in more severe heart failure. Thank you.
Thank you so much, Dr. Ibrahim. That was an excellent overview. Just to remind everybody, if you're listening, if you want to write in questions into our chat, that's fine. If you're watching us live on Facebook, that I know many people are, hopefully we'll be able to get those questions as well. Hopefully Viet knows how to get those ones for us. So our next speaker is actually Dr. Javed Butler, who is one of the Emperor Reduced trialists and has probably been busy in the last few days with our meeting, where this was one of the highlights of the meeting, and that's why we planned our talk for right after, because as if he's not exhausted enough, he should keep educating us on what Emperor Preserved found. But Dr. Butler is the chair of cardiovascular research, as well as a professor and chairman in the Department of Medicine at University of Mississippi, in addition to being a fabulous researcher in the heart failure space. So we're very excited. Obviously, this was a big highlight from European Society of Cardiology, and we're excited to hear the results and what he thinks the takeaways were. Dr. Butler.
Great. Well, thank you very much for the kind introduction. Really, really enjoyed the previous two talks. I have to say that I love the term floating, you know what I'm talking about, but I'll be using it as soon as I know how to pronounce it. I have to say, though, listening to Dr. Hiremath's talk, when he boldly said that who cares about the mechanism of action, my initial reflex was that he's only phenotypically nephrologist. Genotypically, he's actually a cardiologist for sure. So that's great. Okay, so these are my conflicts of interest, and obviously, aside from the direct conflict of interest with Boehringer Ingelheim and Lilly for Emperor Preserved, I've been involved in this trial right from the beginning. So I have a huge sort of intellectual conflict of interest as well. So I hope that I'm objective in my presentation, and if I'm not, please call me out. So Emperor Preserved trial, we know that Emperor Reduced trial showed improvement in outcomes last year, also shown in DAPA-HF. And now the big question was Emperor Preserved. We enrolled patients with ejection fraction 40% or greater than 40% randomized to empagliflozin or placebo. Now, we spent a lot of time scratching our heads about what the hierarchy of the p-value should be. So just these are the sort of details that get lost in the New England Journal paper. But the bottom line is that this trial was only designed to answer these three pre-specified hierarchical endpoints. Primary endpoint of cardiovascular death, heart failure, hospitalization. If that is positive, then the alpha went down to the first secondary, which is total heart failure hospitalization. And if that was positive, then the alpha went down to preservation of the renal function. If that was positive, then we did not bring the alpha down to any other secondary endpoint, said all the alpha was safe for pooled analysis, and hence, other than these three, all the other endpoints are by definition exploratory. So about 6,000 patients randomized to EMPA and placebo, and vital status was known in over 99% of the patient population. Baseline patient characteristics are shown here. So things to note, very high use of RAS inhibitors and beta blockers at baseline, 80 and 85%. So for hypertension, for angina, for mid-range ejection fraction, for whatever reason, these people were very well treated with RAS inhibitors and beta blockers, and actually MRA use getting close to 40% as well. The other thing to notice on this slide, the percentage of women is higher than other heart failure trials, but lower than should have been expected from a HFpEF trial. It's 45%, a lot of HFpEF in older women, but I think the 45% is a reflection of the fact that this trial and also deliver with dapagliflozin is including patients over 40% and not over 50%. And the mid-range ejection fraction is mostly or more men. And then the last thing that I would highlight here is that the event rate in this trial was lower than what we had anticipated. We were anticipating about 10% annual event rate. We ended up getting about 8.5% annual event rate, and about 80% of the patients were NYHA2. So we ended up getting a little bit lower risk population than what we would have anticipated. So this is the primary endpoint. So it speaks for itself. The curve started separating pretty early, continued to separate towards the end of the trial. As you see, the placebo event rate was 8.7 per 100 person year, 21% relative risk reduction, highly statistically significant result. If you look at the components of the primary endpoint, the primary endpoint was sort of the heart failure hospitalization endpoint was diluted, if you may, by the mortality effect. So if you only look at the heart failure hospitalization, there was a 29% relative risk reduction. And if you look at cardiovascular death, there was sort of a directional 9% relative risk reduction, but was not statistically significantly different. Now that we met our primary endpoint, that gives us a reason to move on to the first secondary endpoint. But before we do that, a few of the subgroups that I want to highlight. So the three that I want to highlight, one is that at this point, flozins being anti-diabetic drugs is pretty much, not anti-diabetic, agnostic of the diabetes status is pretty well established by DAPA-CKD, by DAPA-HF, and by Emperor Reduced, and very much same here. There was just no difference in benefit in patients with diabetes or no diabetes. The other thing is that In another HFpEF trial, valsartan sacubitril at the Paragon HF, there was a pretty significant sex interaction between men and women. We did not see here both men and women benefited with the drug. No interaction with body mass index, no interaction with GFR. And then the biggest thing which is on people's mind is ejection fraction. So whether or not low ejection fraction, 40 to 49%, 50 to 60% or greater than 60% made a difference or not. One good thing is that we were worried about imbalances in enrollment, but it turns out that a third, and a third of the patients were in all these three buckets, which gives us a good opportunity to be able to have some robust estimates. And one can see here that the p-value is not here. The New England Journal does not allow you to put trend p-values, but the interaction p was 0.21, so it was wholly negative, and the benefits were seen across all three groups. If this result was just this result and nothing else, we would just move on and we would say no EF interaction, it works on everybody. The problem is that this result is just not this result. This result is in a background of a lot of previous trials showing an interaction with ejection fraction. And if you keep those interactions with ejection fraction in mind, that the higher the ejection fraction, nothing works in HFpEF, one starts seeing a trend here, which is of concern and requires further investigation. In the interest of time, I could have either dug into the renal issues or the EF issues, so I will dig into the renal issues, and I will keep that for Q&A if anybody is interested. So then we move on to our secondary endpoint. So total heart failure hospitalization, 27% relative risk reduction. Again, very obvious and pretty prominent result. So that being positive, we move on to our third endpoint, which was renal function preservation. Everybody knows here that because of the intraglomerular hemodynamic changes, we see an initial dip with SGLT-2 inhibitors, just like we see with ACE inhibitors and ARBs. But after that, there was a stabilization of renal function. So if you look at eGFR slopes, the eGFR slope benefit in favor of empagliflozin over placebo. And remember, we use the word placebo lightly, but I mean, this is 80+% RAS inhibitor use and about close to 40% MRA use. But despite of that, you see this decline in placebo, and the renal slope preservation was 1.36 ml per minute per year. And once you stop both the drugs at the end of the trial, you kind of recovered about 3 mLs of GFR. So the trial was designed to answer these three questions, and all three questions were met, which were highly statistically significant and clinically relevant. Quality of life, again, in the interest of time, I won't be able to go into much data, but we saw quality of life benefit first time when we measured it at 12 months, at 12 weeks, and continue to have benefit at 32 weeks and 52. So benefits were seen early and were sustained. And then this is the similar data with New York Heart Association, that despite the background therapy and the fact that 80% of the people had NYHA2, there was progressive deterioration in placebo designation and improvement with empagliflozin. So this is our sort of beat our chest slide showing the results of Emperor Preserved compared to all the previous HFpEF trials, that this is highly statistically significant and a risk reduction which is substantially higher than what has been achieved with the previous trials. So that leads me to this issue of renal function. So in Emperor Reduce, we saw a pretty robust, I mean, it's one thing to have all these eGFR slope and how to calculate an early dip and later slope changes and what methods to use. We can get into all those debates, but at the end of the day, what the patients want to know is how does that translate into clinical benefit, and the renal composite endpoint of dialysis, transplantation, substantial reductions in GFR, deaths, those kind of things. So in Emperor Reduce, we saw a substantial reduction in renal composite events, which will go hand in hand with what we have seen in diabetes trials and what we have seen in CKD trials. But here comes Emperor Preserved, and there was nothing. We did not see improvement in clinical outcome benefit. So that leads to a little bit of a conundrum as to how to interpret these results. So here's the conundrum, that you have 1.36 ml benefit in terms of EGFR preservation and no benefit in major renal outcomes. So how do you interpret this result? So the first thing to say is, well, 1.36 ml per minute is not important. In Emperor Reduce, it was 1.73 ml. So maybe 1.73 does the trick, but 1.36 is not important. Well, I don't think that the data will support it. So these are the data from a meta-analysis of over 47 randomized controlled trials in CKD patients with 60,000 patients. And the threshold looks like that if you have a renal preservation of 0.75 ml per minute, you almost have a 96% probability of slowing down the renal function preservation. And Emperor Preserved and Emperor Reduced both met that threshold, but in Emperor Reduced, we saw the clinical benefit. In Emperor Preserved, we did not. So the second thing is, what about ejection fraction? So again, my heart failure colleagues will relate hopefully to my comment that this is the benefit that we are seeing. So in Emperor Reduced, we saw the substantial renal benefit, and in Emperor Preserved, we did not, which is amount to saying that some magic happens at EF of 40%, and like, you know, the physiology changes and outcomes changes, and that just doesn't sort of make any clinical sense. So one thing is we looked back at what were the definitions used in the DAPA program where we did see the benefit, and in the Emperor program, and there were two substantial differences. There was a 40% reduction in eGFR for Emperor program and a 50% for DAPA, and they included renal death. The reason why this becomes a little bit important is that if you have fewer events, there is more noise created by 40% reduction because of the initial eGFR dip. So what we did was we matched the definitions for, now again, I'm the first one to say this is all exploratory, but if you match the definition and use 50% reduction in GFR and renal death, along with dialysis and transplantation, the hazard ratio is still non-significant, moves from 0.95 to 0.78. So there's a 22% relative risk reduction in favor of empagliflozin. But as you might expect, the confidence intervals are wide because we have only about 100 events and the event rate goes down. And with that definition, we also see a very interesting ejection fraction dichotomy that the lower the ejection fraction, the more the renal benefit that we are seeing. So we will need to digest these data quite a lot. As you might imagine, we are doing a lot of secondary analyses and a lot of those results will come out. But these are our results. And in the interest of time, I will end here. Thank you so much for inviting me.
Great. Thank you so much for that wonderful talk and really a review of wonderful information that was just provided at the ESC Congress. Next up, we have Dr. Harold Bays. And, you know, we were so worried to have to go up against endocrinology and nephrology that it took two cardiology and a panel of folks that practice cardiology. So I'm just happy to hear that we're actually all on the same page. Dr. Bays is an endocrinologist, as I mentioned, a medical director and president at the Louisville Metabolic and Atherosclerosis Research Center. And we are just happy to have him. Would love to hear your thoughts on the team sport of initiating these flozins.
Okay, well, thank you very much. As you mentioned, my name is Harold Bays. I work as a clinical trialist here in Louisville, Kentucky. I've been a principal investigator somewhere over 500 clinical trials spanning about 30 years. And it's just so interesting to see the ebbs and flows of clinical research. When I first got started, we were working all the statins, and there were the ACE inhibitors and the ARBs and the calcium channel blockers. And we just thought it was going to go on forever. And then it didn't. And we ran into some rough times. And we had ezetimibe and PCSK9 inhibitors, but a lot of the other drugs that were supposed to make it, like the PPAR alpha gammas and the cannabinoid receptor antagonists and the squalene synthase inhibitors, and on and on and on. They never, and a lot of these didn't make it because of the kidney. Okay, because of the kidney. So it's been quite a ride with the flozins. And the perspective I want to give from an endocrinologist is that I guess I'll just speak for myself. I was definitely not a flozinator right at the beginning when we were first doing the trials with these, because I had no idea what they were going to prove to be. And before I get into my talk, I do want to say this. You can see here, again, I'm from Louisville, Kentucky. I was in Minneapolis in a connection flight. Flight attendant came up to me one time and said, where are you from? And I said, I'm from Louisville, Kentucky. And she goes, oh, I thought you were from Canada. Like, why did you think I was from Canada? She says, because you look Canadian. I don't know how a person looks Canadian. Maybe it was the BlackBerry I was carrying, but all right, so here are my disclosures. Again, do a lot of clinical research, pharma research and such. So I just wanted to give you a perspective from an endocrinologist about these flozins, okay? So there are these two classes of glucose transporters. I mean, that's the way we understand it as endocrinologists. There's actually 14 isoforms of facilitated passive glucose transporters and, 6 SGLT1s. Here you have the GLUT2 and the liver and the kidney and GLUT4 and skeletal muscle, heart, adipose tissue and such. I guess I should add this. I do a lot of research in obesity, and I'm going to swing back around to that at the very end. So a big focus of my clinical research and the publications I do is on obesity. And here we have the SGLT1 and SGLT2. And that becomes important because, I'm going to go ahead and tell you the punchline before I tell you the premise. But there has been a thinking that, as if the flozins weren't good enough already, there's been a sense of, what happens if you could combine a SGLT2 inhibitor with an SGLT1 inhibitor? And with the SGLT1 having to do with transport of carbohydrates and such, is it possible you could get substantial weight reduction in addition to everything else? And I want to talk about this. So here's the very simple diagram of the renal handling of glucose that we all know. And as was previously mentioned, this was first discovered at the root bark of apple trees. Folks that I was around at the time, and again, this is decades ago, they were using fluorescein. Fluorescein is a SGLT2 inhibitor, but it's got some SGLT1 inhibition as well, but not very well tolerated, not very well absorbed. It was given either subcutaneous or intravenous, used a lot on animal studies and such. And so we've known about this class of agents for a long time. It's just, I just don't think people saw the promise in these drugs. And in fact, I sure didn't. So I write this article almost as a defensive article. So we had, again, done several clinical trials with several SGLT2 inhibitors, and there was a concern that if you're going to be urinating out glucose and having polyuria, that'd be a really bad thing to do in patients with diabetes. It just didn't seem to make sense. So the whole intent of the article, you can see here, I don't even mention SGLT2 inhibitors, because the whole concern at that time is the endocrinologists were worried that maybe you're doing something bad to the kidneys. And so the title of this review article is From Victim to Ally. The kidney is an emerging target for treatment of diabetes mellitus. So trying to turn it on its head that maybe a mechanism that caused polyuria is a good thing. And then came the IMPA-REG study. And I know you folks that deal with this all the time, maybe it still doesn't have the allure that it does for clinical trialists, people like me, but we weren't even a site. We were not a site in this study, but my goodness, I never saw this coming. I thought SGLT2 inhibitors would be okay. I thought they might do okay in the market, not particularly well as an endocrinologist, as a clinical endocrinologist. But when we got, before I get to that, it wasn't just me that had a lack of confidence. For those of you that work a bit with statistics and such, I think you can tell a lot about a particular company or person's confidence in what the drug is going to do if you look at the statistical methods. And look at the first two tests in the hierarchy, non-inferiority and non-inferiority. We've done a lot of trials. I don't know. That's not a big stamp of confidence there when your first 2 points in the hierarchy are non-inferiority. So I think that just speaks to the unexpected nature of the outcomes of these studies. And of course, we all know the end of the study because we've We've seen them in other slides. I mean, they were amazing. Yes, there were some, there can be some small increases in LDL cholesterol and HDL cholesterol. Maybe there's some reduction in body weight. And yes, there's the increased risk of genital infections and such. But this idea that in addition to reducing 3-point MACE by 14%, you reduce hospitalization for heart failure by 35%. Maybe the cardiologist saw that coming. As an endocrinologist, I never saw that coming. Reduced cardiovascular death by 38%. Are you kidding me? Reduced all-cause deaths by 32%. I mean, if we had any lipid drug that even approximated this, I mean, we'd be going crazy. So this was quite amazing. And then, of course, this was followed up, and you've seen iterations of this slide in other presentations here. We just talked about the IMPA-REG outcome and Canvas program, DECLARE, Credence, and such. And then the outcomes where some had reduction in the major adverse cardiac events, some had decrease in cardiovascular deaths, but that reduction in heart failure and reduction in kidney progression, which again, in the day, that was the concern that endocrinologists had. They thought it was going to make the kidneys worse somehow. So this just proved to be, I mean, look, there was so much concern that the dapagliflozin had to go in front of the FDA twice in order to get approval. And I know this because I was one of the presenters in front of the FDA advisory panel talking about dapagliflozin. So again, just a total crazy ride with the SGLT-2 inhibitors. And then, of course, you've got whole issue with the heart failure that we talked about. And that's the reason that the American Diabetes Association has really just changed the paradigm. Yes, we have nutrition and physical activity. Yes, we still have metformin. But now you got to make a decision. Where are you going next? And where you're not going next is you're probably not going to go to a DPP-4 inhibitor, which is where I think a lot of people thought was going to be the big dog, or you're not going to go to a PPAR gamma agent. Endocrinologists don't use them very much anymore. And there are various insulins you can use and such, but these drugs have just really changed the way that we practice management of our patients with the diabetes mellitus. And it all comes down to what we call pipes and pumps. If it has to do with the pump, I think you're going to go with an SGLT-2 inhibitor. If it comes down to pipes, we're going to have to wait and see, but it's quite possible that there's still going to be a role for GLP-1 receptor agonist. So here's just again, just sort of a time capsule about where we thought we were going and what we thought was going to happen. Here you had a drug like empagliflozin, me being a newly appointed flozinator here. Here's empagliflozin. It's a SGLT1 and SGLT2 inhibitor. And the thinking was it was going to not only have the benefits of the SGLT2 inhibitor, but also give you that weight reduction. And it just really didn't do that. So it just had very modest weight reduction. So I don't think you're ever going to see these drugs be weight management therapeutics. But you could see that maybe they're combined with other things, just like we combine other things to treat the diabetes and hypertension and dyslipidemia. And it is interesting that you do get some weight reduction equivalent to the glucosuria. And we showed that with the canagliflozin, really. And this is in patients with obesity who didn't have the diabetes. So overall, just from an endocrinology standpoint, very exciting advancement in treatment of our patients in multiple different ways. And with that, I'll turn it back over to Martha or whoever.
Fantastic. Well, if we can stop sharing the screen, we can get everyone up so that we can have a little bit of a discussion here. But I would like to start with Dr. Butler. There is a question that you might have seen all over Twitter related to this trial. There were some people unimpressed with the results related to the fact that the benefit with Preserved was related to heart failure hospitalizations and not mortality. And there were people that said other trials have shown this. Why are you all excited? Despite this being the first trial to meet that kind of primary endpoint. So I just wondered if you could shed some light, Dr. Butler. I don't know if you saw that discussion. There was people, I think some people thought it was non-heart failure doctors. Just for full disclosure, I'm not a heart failure doctor. But I think the data was quite impressive. But maybe you could shed some light on what that meaning is.
So the easier answer is as to why I'm excited is because I did the trial. So that's a simple answer. But the bigger question is, why did we not see a cardiovascular mortality benefit? So, I can sort of give you a little bit of a geeky answer to that. The simplest answer would be, well, maybe this drug doesn't reduce mortality. So sure, that's possible. Second issue is that, we know that in patients with HFrEF, about 85-90% of the mortality is cardiovascular. And in that 85 to 90% of the mortality, 80% of the mortality or so is only because of two reasons, sudden cardiac death and progressive pump failure. So it's a very narrow cause of death, and the pathophysiology is the same, so you can affect it. Now, in patients with heart failure and preserved ejection fraction, about 30-35% of the mortality is non-cardiovascular, and the cardiovascular mortality is really heterogeneous. You have your strokes and MIs and all that kind of stuff. In this trial, we particularly got a little bit more unlucky that 50% of the mortality was non-cardiovascular and only 50% of the mortality was cardiovascular. I really haven't digested all the data, but it turns out that we had a pretty significant amount of death which was related to infectious diseases. There was no imbalance between the two arms, but overall was a little bit high. And we are trying to dig into what happened in the COVID era and infections and all that kind of stuff. But only 50% was the cardiovascular mortality. So that's second issue. But honestly, if you ask me my reason why we did not hit cardiovascular mortality, again, the drug may not have an impact on cardiovascular mortality, and that's always the case. But when we started doing heart failure trial in the 80s and 90s, we were powering all the trials for cardiovascular mortality. The cost for those trials in this era has become so much that now all the trials have heart failure, hospitalization, and cardiovascular mortality as a combined endpoint. So what ends up happening is that these trials stop when you achieve your previous number of events, whatever, 832 events in this case. So these in high-risk patients, more than half the endpoint to begin with is hospitalization, less than half are mortality events, and those less than half mortality events were only 50% cardiovascular events. So at the end of the day, my bias is, and again, I'm looking at the trial with rose-colored glasses, so that's a problem, but it is what it is. I think that 2 years is a decent follow-up, but in a HFpEF population with that kind of non-cardiovascular mortality is probably not enough. And that 9% mortality probably would have expanded if we would have waited longer, but obviously we could not.
That's great. And I think there's a lot of rose-colored glasses on this panel, so it's okay. Dr. Ibrahim, what's your thought? Because you take care of these patients day in and day out. I see a lot of them taking care of women in general. A lot of them present like this. But what have we been doing with these patients up until now?
Nothing really. I mean, they're in and out of the hospital. They come in with acute decompensated heart failure. That affects their quality of life. So if you're telling me my patient that has HFpEF and there's a drug that can reduce their heart failure hospitalization, which in turn means improving their quality of life, because every time you're admitted, you take several steps back, especially older patients. It takes longer to recuperate and really get better. And what we're doing is blood pressure control, diuretic management. We're trying maybe devices like implantable monitors, like CardioMEMS, to see if we can keep them out. But I'm excited about this, and we'll be prescribing SGLT-2 inhibitors to patients with HFpEF.
It looks like there were a couple of questions in the chat here. And it looks like Dr. Hiremath is answering some of those. I don't know if you want to answer that out loud,
Sure. Yeah. So the question from Laura Ross was, what kind of lab are the fluosinators checking before or after starting a fluosin? And I kind of paper, I mentioned that very briefly or very lightly. The trials with fluosins have gone down to a GFR of 20, and we had also asked that question before. So none of the trials initiated a fluosin below a GFR of 20. Having said that, in say Credence or DAPA CKD, once a fluosin was started and the GFR dropped, the fluosin was not stopped, right? So it was written all the way to dialysis because it still has an effect and it's not doing anything bad to the kidney. So there is a protective effect that is going on, but it wasn't started below GFR of 20, which may change with EMPA kidney coming out next year. So that's first. The second is you will see a creatinine bump, right? Like you see with ACE inhibitors or ARBs. It is not meaningful. It is just hemodynamics. There is biomarker studies showing that the creatinine bump is not associated with any tubular injury markers going up. So though people like to check it, if it is going to make you stop the fluosin, it's not a good thing. And it is just noise that you will see. So in general, if it is possible, I would like to persuade you to, take a deep breath, be brave, and not chase the creatinine going up and down when you're initiating a fluosin. A couple of points though, unlike ACE inhibitors or ARBs, where, you're worried about the creatinine going up and up and up, if there is bilateral renal artery stenosis, etc., you're not going to face that situation. But there is the occasional patient who has severe hyperglycemia, who has a huge amount of glucuresis and nitriuresis, and they get, volume contracted. Yes. So if symptomatically you're seeing something that is suspicious, sure, chase the electrolytes, but don't panic and just keep measuring electrolytes is my suggestion.
Keep calm and fluosin on. Is that
Dr. Butler, there's a question from Dr. Cohen asking if you could address the apparent lack of benefit of those on MRAs at baseline.
So I think those that were not on MRAs had a point estimate of 0.78, and those on MRA was 0.86. Obviously, MRA was a small group, so it had a wide confidence interval. But the point estimates were both comfortably on the left, and the interaction P was negative. So we'll obviously dig into more details if there is some attenuation of benefit, but at least at the superficial level, both of them benefited. So I'm not sure I would say that there is lack of benefit in those with MRA.
Great. And Dr. Bays, what's your experience? Who's starting the fluosins? Because that's always has been an issue in the cardiology community, maybe not in the heart failure community. I think they've been very proactive, and the nephrologists apparently want to put it into the water. And endocrinologists obviously have always been comfortable with this. But I think a general cardiologist, I think many people hesitate. So I was wondering, how do we get over that? How do you partner with them as an endocrinologist? What do you tell them? Who monitors what after you start them?
Yeah, I think, so that's a great question. I think that the biggest issue is the same one that there's always been an issue, and that's inertia. There are still clinicians out there that use a whole lot of DPP-4 inhibitors. And inexplicably, there are a lot of clinicians out there that are still using a lot of sulfonylureas. And as you know, the endocrinologists sort of abandoned the sulfonylureas a long time ago, but the retort that you hear is, well, but my patient can't afford these other drugs, and these are the only drugs that are available. And I think if that's actually true, I mean, if it's a difference between that and going into hyperglycemia coma or something, I mean, you got to do what you got to do. But sometimes I think it just comes down that, I mean, look at all this wonderful, everybody here that's presented, all this wonderful cardiology and nephrology data and everything. And yes, I think all you folks know this information, but I really wonder how much the primary care clinicians, whether that's really kind of sunk in, this sea change and the indicated use for these drugs. I mean, it's just, again, it was unexpected, it's remarkable, and it's been fairly recent. So I guess my answer to your question is, if I had to pick the biggest impairment or impediment towards the use of these drugs, and the thing that is most influential in partnering up with folks in order to use these drugs, it's just, how do we get the message out? And how do we get primary care clinicians to better understand that this is really big stuff. This isn't some marginal that barely meets a p-value of 0.05, whatever. This is clinically meaningful stuff in a way that it just doesn't come around very often in a lifetime.
Yeah, I think this is a real game changer. And I know people use that term loosely, but I think for this, we're really seeing something else. Does anyone want to comment on this in terms of where it's going to fit in overall in our cardiology guidelines? Do you think that even the way that we're recommending metformin still first and foremost, does that have to do more with cost and less with evidence?
So I mean, I can take that. Go ahead.
Okay, just briefly. I mean, this a lot of times this comes down more to opinion than the data, because we don't have comparative trials, whatever. But I think it would be fair to say, at least the last time I took the literature, that over 70% of the people that got in these trials were on metformin. So a large amount of the data that we have is on a background of metformin. Okay. And then the only other thing I would say is, you talk about game changer. I'm just going to throw this in here before we end up. Just as there's a game changer with the SGLT-2 inhibitors, buckle up, folks, semaglutide, you're going to hear that term being used for that drug as well. So, and then tirzepatide's coming down the pike. There's a lot of stuff going on in the endocrinology world that all you cardiology and nephrology types, it isn't just SGLT-2 inhibitors, a lot of other stuff going on.
So first of all, tirzepatide is going to take over HFpEF treatment. That I can officially say today. I can officially say that today.
Yeah, I think I was being specific about diabetics, but yeah, I agree. We have no other medication in the HFpEF world, you know, diabetic or non-diabetic, that we need to have something for this population. So I think we're just went a little bit over time, and I don't know if Sohail wants to wrap us up, or Viet.
I would like to defer to Sohail there.
Go ahead, Viet. That's okay.
Well, you know,
I'm still half asleep. But I'm listening to this great
barely
talk.
woke up. Yeah. No, thank you, everyone. This has been really a wonderful discussion, very engaging. I've loved to watching the chat. Hopefully you'll continue the conversation on Twitter, on Facebook Live, as it went live. And I did not see any questions cross over there, but thank you to our panelists for taking the time. We recognize that it's a lot to put together these talks, and we're grateful that you're giving back to the community and giving of your expertise. So appreciate all of you, and congratulations, Dr. Butler, on a wonderful trial that was presented and gave so much great data for those of us who treat and see HFpEF. That was fantastic. So thank you, everyone. We'll send out a link to our webinar video, and have a good night.
Thank you.
Thank you.
You can get your
Thank you
CME
so
as
much.
well, to do your CME things as well. We are
That's
getting
right.
ready.
Yes. Don't forget to get your CME. It's so important.